So I formally welcome Professor Ritu Priya to deliver her talk for today morning in day 2. And allow me a moment to introduce her. So Professor Ritu Priya is a medical graduate with a doctorate in community health, is a retired professor from the Center of Social Medicine and Community Health, JNU, New Delhi. Her work links epidemiology, popular culture, and political economy with health systems analysis for developing an understanding of health culture, as well as drawing upon it for a contextually suited health systems development policy. It has been specifically focused on the politics of knowledge between healing systems and between experts and lay people, health perceptions of Dalits and other marginalized groups, urban health, nutrition, and communicable diseases. She has been advisor public health planning with the National Health Systems Resource Center and under the NRHM, the National Rural Health Mission, and has also been actively involved with people's health movement in the country for over 3 decades. Warm welcome, Professor Ritu Priya. Please share your thoughts with us. After you will be Dr. Rashmi, and then Sujit and Venkat. So 4 speakers for the morning session. Warm welcome. Please come.
Well, I was keen to hear about what happened yesterday afternoon because unfortunately I couldn't be here, and it was about systems development and so on. I didn't want to be, I would have liked to actually be there and hear what he had to say so that one could move from there rather than overlap issues. Is English okay or? So now when we look at designing health systems, and clearly from the morning yesterday, health systems is not only what the government health policy is about, which is about the institutional structures. What we talk about when we are saying health systems here, and we are talking of pluralism and bringing in multiple knowledges, we have a big challenge. And that's a challenge that in this country we've been discussing and trying to deal with for over 100 years. During the time when the British were ruling us, the debate was already on, and it has continued right up to today. Just before COVID or during COVID, the Niti Aayog attempted to get several health system designers together and do workshops to try and figure out how to create an integrative health system. And my understanding from that exercise was that they really couldn't come up with how to do it. And that's therefore a bit of a puzzle. I mean, today's day and time with sustainability science, which is opened out from the classical positivist science to much more of collaborative science and so on, one would have expected that experts of the country would have come up with some kind, and in our kind of context where we have 8 officially recognized systems, we would by now have worked that through. But we obviously haven't. And so I partly will try and sort of spell out what are the challenges as I understand them, having engaged with the Ministry of Ayush and the ministry and what we teach in academic public health and health systems, and thereby where are really the gaps because of which, and kind of blocks in our mind because of which we are not able to think of integrative systems. Yesterday's morning clearly showed us that we need integrative self-care. And that is something which most of us, if we just think back on what our families do when we have illness in the family, we're all doing integrative self-care. At least most of us are. So that is one part of it. But there are challenges there as well. And I think we are all aware of the fact how changes are happening in our lifestyles and so on. And therefore, how do we need to do some more thinking around that as well. But we need further beyond that, integrative patient care. And again, we had Dr. Kamar speak about how homeopathy and its place in an integrative kind of structure. So that, as well as today you have most of the big corporate private hospitals all have a unit of Ayurveda and homeopathy now attempting to work together. So this realization at the patient care level is already there and already coming into practice. And it's been there in various states all the time, but today it's now again getting institutionalized in some form. But how does it happen at primary, secondary, and tertiary levels? Everybody thinks of, is okay to say, "Okay, you do what you want, communities can do what they want at primary level." But anything a little more serious, then it must go to the dominant form. But obviously now, if it's reaching tertiary hospitals, it's showing that there's more need at each of these levels. So what do we need to think of when we are designing systems for it? This is all happening sporadically and as people feel the need. And the third is we need an integrative public health. Because the preventive that yesterday everybody spoke about gets institutionalized through the public health dimensions in the dominant modern system. And yet it doesn't seem to have enough thinking on this, picking up from all the other knowledge systems that are there. So I would say that if we want to design and think of a health system as a comprehensive health system, we'd have to work at all these three levels of an integrative self-care, integrative patient care, and integrative public health. Now, and what would integrative public health do? It would have to move well beyond health service systems and into looking at, therefore, what kind of food do we need, what kind of food processing do we need, what kind of dietary guidelines that are given all the time to be done, what is a balanced diet is what we are all taught in school, but should it be somewhat different and more flexible by the diversity that we heard of yesterday? What kind of living and working conditions? So really, we'll have to look at a whole spectrum of things if we want to look at it as integrative public health, where again we don't think of only the modern dominant way models that are before us, but also all the wisdom and knowledge that we have around us for a long time. And we fortunately still have some people, and these are surviving traditions in our context. In school education, to higher education, to medical education, what is it that we need to do if we want integrative systems? Some of these are fairly obvious things, so I'm not sort of spelling them out. Sports, exercise, leisure time, how do we want to design it for our children, for adults, for elderly? All those are wide of issues for public health and for health at large. Environmental pollution is the big, relatively new entrant, new meaning in the last 100 years. And how do we mitigate that? What are the measures we would need to do that? Collectivization of communities is now become an issue for health systems, which was almost naturally there in earlier times, but now our social fabric is not as robust as it used to be, and there is clearly a decrease in social cohesion within families and between families, between communities. And therefore, that again needs to be brought back for community well-being and certainly for community health action. So one challenge when we're talking of design is something which is a planned designing process. Therefore, we are talking of institutional structures which tend to be top-down. But how do we therefore include the bottom-up experience and bottom-up needs, which need to be, as yesterday again was pointed out very clearly, they have to be contextual and therefore diverse. It's not one universal model that we can create, and therefore the decentralized processes that are required for doing this. But the bottom-up process is something which today is talked about a lot, but one finds that when it's whatever is being really operationalized on the ground, it somehow tends to end at best as what we see of that bottom, and that is become diverse because we have become distant from a large majority of people. So how do we make that link between bottom-up planning and what that requires and the top-down institutional structure which is going to plan and create the designs for society? And at the societal level, today the state becoming the major planner and designer of our societies. So how do we manage this challenge? What have been the challenges to this? I see a major problem that has arisen is because of the positivist nature of modern science, which says there is only one singular truth and only science can give you that. It is only the scientific method modern scientific method which gives you that one truth, which is what is then universally true and applicable. And that is something that is drilled into us from our educational system in school onwards. That is what at the time of independence our planners lived with. And certainly at that time there was technology, there was medical science and technology which everybody was in awe of. There were the new antibiotics, there were the painkillers, all of which were magic bullets. And therefore there was a lot of awe of that. And therefore the planners saw that as the basic. So when we had even committees, for example, which were the committee on which our blueprint for health system is built, the Bore committee, was primarily modern medical doctors, and that too completely decreed that these other systems must just die out. We don't need them, now we've got the science. But fortunately, because our political and cultural context required it, therefore all the others survived, even institutionally. But even the committees which meant to look at that, there was the Chopra committee, etc., which were to look at how to do the integration. And they all thought that integration eventually had to be modern science as the reference point, and everything integrates, we see what is good in the others and integrate it there. So, but the idea being there is only one science. So we have to create an integrative one science. Is that how we want to see integration? That to me is one major question, because even today when, for example, the National Rural Health Mission does co-location of various systems, that is in one PHC or one hospital, we have people of Ayurveda or Unani or homeopathy and so on, and along with the modern system, one would imagine it would mean allowing dialogue and cross-talk. It would mean integrative patient care. But the mind doesn't allow that to happen, because we are in that mode of integrating everything into modern medicine. So even these doctors, at best, if they have medicines, their own system medicines in the PHC and hospital, they may use, states ka alag alag hai. Many states have and many don't. But even then they are still required to practice the allopathy that is part of the modern system. So, so is that the integration we want at the patient care level? Or is it that we would want each one to grow in its own and practice in its own wisdom with its own genius, and so you have 8 different systems being practiced simultaneously and being allowed to do their own research, to grow, to develop their own educational systems, etc., which is what we have actually adopted, as distinct from China, which has done a much more amalgamatory exercise. We still have this diversity of 8 systems, and we've got their councils and their medical colleges separate, and so on. So therefore I think that is one positive which we already have in our system. Now one way would be to go in the way the dominant planning process goes. We start top down, we say, okay, we have so many Ayurveda colleges and so many homeopathy colleges, we need so many more because the population needs so many doctors, therefore let's build so many more hospitals, right? Or medical colleges. And then we try to see how we fill this shortfall. The other is to say, what is it that people are doing? Which one do they use? Why do they use it? And thereby see what do we need from there upwards, and what are the challenges people are facing. So for example, you'll find when we're talking of home remedies, now people are saying we don't have the plants that we used to have around us. The forests have gone far away, and therefore we can't find those. The community healers that were there, some continue to be there, some have migrated out of the villages, or their children have stopped practicing because it wasn't legitimate to practice. So therefore, how do we now handle these situations? Would become part of what we need to plan for and design for. And therefore, how do we match between these and prioritize and so on would be issues that we look at. So this positivist modern science and singularity of knowledge is one major channel that we have to break. And sustainability science is helping us do that. The other was the Descartesian body-mind divide, which clearly put out in the modern medical science and its practice the social environmental to an extent, but the social and spiritual dimensions had to be sifted out completely. You now have elements like in the frontiers of modern science and modern medicine today, biopsychosocial approaches which are attempting to correct this kind of a divide between body and mind. Otherwise, it used to just get labeled as psychosomatic. So only some diseases, asthma hai, allergies hai, they are psychosomatic. But the rest is all body is body and mind is mind. Now we know that that's not true. There's so much, it's so closely interknitted. And homeopathy, of course, has always taken that into account. So we heard about that yesterday. So, but in the popular practice, and what is today, modern medicine today, at least in public health and health system literature, is called conventional medicine. And I was writing something in Hindi, and I realized when you say conventional medicine, it becomes paramparik. That's the only term we have for it. So traditional and conventional are both paramparik, because conventional medicine now has been practiced across the world for at least 100 years. So a 100-year history makes it something which is conventional or traditional. It's not ancient tradition, but it is something which is widely accepted there. Therefore, now when we're talking of...
It's similar like energy. Coal and petroleum have become conventional energy.
And you're getting the alternates. But alternate now is not going back to the easily available raw material. It's solar and it's still technologies like that. So this is one whole area of the knowledge systems and how do we break through them. The second big challenge is the political economy and of the medical industrial complex, which is the largest economic block now after IT and defense maybe. And the patent regime that goes with it, that places on innovation and research as an individual phenomenon and gives an individual or a industry the ownership of that particular knowledge. And here we are trying to fit traditional knowledge into that regime. The World Intellectual Property Rights Organization has just signed an international treaty. It was a very interesting process. Over 20 years, that treaty was debated, and hotly debated, because there were two sides to it. They were actually called Group A and Group B inside. Group A was the high-income countries and their industry, pharma industry. On the other side was China, India, Africa, Latin American countries. And the two were battling several kinds of issues on what to sign, and what were the most contentious issues was mandatory. Should they declare where they got the original knowledge from? Till the 1950s, most drugs came from traditional medicine and its knowledge, and then were converted into molecules and pharma products. Now they're again back to bioprospecting to find these, because it's easy. You already have the knowledge of the community. You only have to go and do work in the lab to find that. Other than picking up random chemicals and trying to work out what could their medical product be, which is what pharmacology otherwise does. So how do you put that patent? Now what WIPO has now done is they didn't, sorry, I was just deviating from this. I was talking about WIPO's debate, which happened on two. One, mandatory disclosure of source of knowledge. Two, it actually had a clause which said that those who use this knowledge, so the industry, for example, pharma industry can use it, but it will have to get a patent, it will have to do some innovation with it, which would likely be pick up the active molecule and make that into a drug from the whole plant. And in doing that, the clause was that those who use that knowledge must be cognizant of and moor themselves in the culture from which it came. Now that would have meant a completely different thing if every box of a medicine had to say this came from tribes of Kerala such and such. If this said this had to come from Odisha, this came from Australia, and so on, it would start questioning modern science's supremacy. Because here, that is what has created that supremacy, that they came with magic bullets for us and saved our lives. Now here we are saying that what you are taking and selling across the world is what you've got from us. And that is not something they're ready for. So it was hotly debated, and it's not in the treaty, which all of us have signed, including India. It's not there any longer at all. The cultural dimension didn't even get discussed. It was just quietly dropped because nobody could think of how will the modern medical industry and pharma industry be able to deal with the culture, acknowledge the cultures of these societies and use them in their processes. I also can't imagine how they could have done, other than really turning science completely on its head. Would be a completely different way of handling it. So that has not been allowed to happen. And also we have these two international treaties being discussed, the pandemic treaty and this one. This has been passed quietly, signed. The pandemic treaty still remains under discussion. Now what this basically I'm talking about is the corporate medical industry and what it is doing, which includes pharma like this, but it's also equipment. Today it's diagnostics, which is the heaviest, and now insurance industry, which has now entered our country as well in a big way. So all of this together becomes the complex and the patent regime. And unfortunately, Ayush is falling into the trap of emulating each of these. Our medical education is being questioned, and its regulatory mechanism, the MCI, had to be completely modified. That is why we stopped the MCI and have recreated a new institution, the National Medical Commission. And across the globe, this model of regulation of medical people as self-regulatory by the profession, which is what it used to be in the 19th and 20th centuries, us taking it from Great Britain in the model that was there, everybody has given it up because that self-regulation does not seem to have worked. Everywhere it's been seen that there has been unethical practice and so on and so forth. And therefore, the bringing in of not only doctors into that regulatory system, but also laypersons and other socially active persons has been the mandate everywhere. So that's only an indicator of what we are missing out. But Ayush now has the same kind of medical college modeled on medical college lines. The graduates are the only recognized practitioners today officially. The ones that by lineage or Guru Shishya Parampara are quacks, and in states like Kerala, they're even banned to speak and practice in public. So we're now moving into that kind of a frame where they are getting pushed out. For even the pharmacopoeia, which is the list of medicines and how they work, the Ayush pharmacopoeia is trying to make one pharmacopoeia of Ayurveda for the country. We know that Kerala and Banaras and Jamnagar have different medicines that they use. But now the homogenization of into one is what is coming in the name of standardization. So while the system needs standardization of some kind, if it has to do mass, either rules or guidelines or delivery of services, I think we need to be cognizant of trying to keep that diversity still there. So how do we keep even standardization flexible and open is something we need to think about in the system's design. Part of the knowledge issues problem that's always raised is about the evidence of proof of efficacy. And homeopathy knows it no better than any of the others. Now here I sort of sit on both sides of the debate, because I do see that a lot of the time, and for example, there is solid evidence data that something even like TB, there is spontaneous cure in 40% of those who actually get manifest TB. We don't need any drugs, 40% the body will cure itself. Okay, so now that is what happens when any of us get any illness, that some spontaneous healing occurs. And that's what all systems benefit from. Because if I believe in allopathy and I take allopathic medicine, I will believe I got cured because of that. And it reinforces my belief. If I believe in homeopathy, I will take homeopathic medicine and I will get all right, whether it was by nature's doing or by the homeopathic medicine, and I will believe it was homeopathy. And therefore it reinforces And all practitioners will know this. I don't know if you will corroborate what I'm saying. So this is a great benefit that all practitioners of all systems avail of. Therefore, when we want to actually know objectively, does a medicine work or not, we'll have to go beyond just practitioner experience or patient experience, because it is this reinforcing process. And therefore, there has to be some objective way by which we identify, okay, this particular drug or regimen has this much effectiveness, some measure of that. We cannot base all our decisions on that, but that is the first base on which we should look to say, okay, this is something that we can use for this particular problem. Then do we want to use it in this context and not in that context is the next step. But so therefore, I see the RCTs as something helping to other randomized clinical trials, of which there is a lot of critique and there's a lot of valid critique. But I don't want to throw away the baby with the bathtub, that we don't see any value in RCTs at all or ignore them even when the data is there saying it's a problem when it is industry done, because then there is conflict of interest. But otherwise, it is a process by which as human beings we can try and understand what is working at the physical and psychological human level in terms of treating a particular thing or preventing something, some health problem and so on. But will it actually work in a particular context or not is the next step of research that needs to be done. So you need to be able to say under which conditions, and we have sthan, kal, prakriti, all of that can be factored in to say, will it work there or not work there? So in fact, RCTs today that Ayurveda, for example, is undertaking, none of them are taking prakriti into account. I just don't understand how Ayurveda research can happen for the effectiveness of particular regimens and medicines without taking prakriti into account, with my very limited understanding of Ayurveda. But this is a basic that I understand. And please correct me if I'm wrong. But I've sat on ethics committees of All India Institute of Ayurveda and so on, and none of their research is. And when I ask that question, they say, "जी आजकल तो practice में भी कोई नहीं देखता उसको, अब क्या करें?" तो, and you're trying to see efficacy with principles. So here I'm arguing for being allowed to do research under principles of that science, and that science itself is trying to emulate modern medicine and give up. But there are some very interesting examples where RCT has been done keeping the Ayurveda principle, and a very well-known study was on rheumatoid arthritis done in Coimbatore, where with Ram Manohar as the lead from here, they treated some rheumatoid arthritis patients, American patients, where they were not getting better there, and they were on things like the anti-cancer drugs and so on for it. So they had come here and they got treated and went back. So NIH people came, the National Institutes of Health of the US, asking the Coimbatore team, can we study what you're doing? So they said, sure, do that, but we won't change our system of treatment for your study. He said, okay, so what is it that you require? He said, we don't have one molecule, we don't have one drug, and the RCTs require a very strict protocol. This much drug, so much dose will be given, all that is set out earlier, and you cannot change it during the study. You can do another study later if you think it was wrong, but that study will have to take only that. Now they said, we will keep changing, and the same patient we will give 5 different regimens as we go along. As the patient's condition changes, we will change our medicine. So they said, okay, they worked out, the NIH team, that we'll do Ayurveda treatment versus methotrexate. That was their drug that they were giving. And they kept these as the comparative arms. And then as they were doing it, what they had in their protocol was that once the drug is given and you're following up to see various indices and tests and all that, it is done for a certain period of time, 6 months or something, and then you see follow-up for 6 months. So they said, no, sorry, we won't do follow-up, we want follow-up for at least 9 to 12 months. Why? Because we have seen in our patients that initially results are slow. It is at 9 months that real change happens. So the study was done, and at 6 months, methotrexate and Ayurveda treatment was at par. And 9 months, the Ayurveda treatment had overshot the methotrexate results. So the NIH had to change its very sacred RCT protocols to keep to the principles of Ayurveda rather than do it the other way. Now, this is an excellent example. I always feel so happy whenever I think of that kind of a situation where NIH is made to change its entire system the way they worked at it. And it's well recognized. The study was then awarded and so on, has been internationally done. So, but then why is that not being followed subsequently? Now you have a kind of example from which you can learn and draw how RCTs can be designed for Ayush, keeping the various diversities into account. You could make 3 arms with 3 different prakritis if you want and see how the drugs could work. I mean, that's a but of course it increases then the sample size you need, it increases the time and the resources, all of that. But yet I would think if Ayurveda wants to stick to its principles, this is one of the basic things that it needs to do in its research. So I was really very impressed with Dr. Khamar, because about the first time I heard saying that we try and figure out within the entire patient care, where is it that we fit our system and where we fit ourselves. Because each system has strengths and limitations. And if one has a general idea of where it fits, then people know. People have worked out through experience their rule of thumb. For what to go where, they have worked out their systems. The health-seeking behavior studies that we do. So their rules of thumb are clear where they will go for each one. I won't elaborate on that. Many of those who are working with communities and patients will know. Now, therefore, what I'm really pointing out is how do we create what we need to do. Now I'm just coming to that, to create the bridges between the different systems, between the healthcare systems and the other systems that we need for preventing health problems. And there are examples that we have which have been attempted, like I said, NRHM doing the National Rural Health Mission, attempting to do co-location. If that can be operationalized to actually mean interaction, then it will be useful. If those sitting together in one institution actually are trained to know when to cross-refer. For what diseases is my colleague better, and therefore let me send there. And some people have worked it out. Between them, there's an informal cross-referral, but it is not formal. And we did a study across 18 states in the Rural Health Mission, and what we found was that the cross-referral is happening, and more than 50% of allopathic doctors in the public system said they were doing some of it and that they saw value in other systems. Yet they wouldn't write it down. They would tell it verbally. Homeopathy ke paas chale jao, wo acha kar rahe hain, wo Vaidji ke paas chale jao. But they will not write it because it is considered illegitimate. And they wonder whether they are actually being disloyal to their system, and therefore will not write it. Now we need to break that and say that this is legitimate. But there need to be some cautions. Today the medicine, can they interact? If the medicines interact, do we need to change dosages? Do we need to give one early and give one with a gap, or not give one at all and give the other? These are all things that need to be researched. They can't just be done. Individuals can do it for themselves for a small number of something. But as systemically we need to, if we want integrative systems, we need to do that kind of research to figure that out. The herbal medicines today are growing in the same soil and with the same water and air that we know is contaminated. Do the herbs have that purity or that effect, or can they also have negative effects? We need to test that out. So there is that kind of research that is required to figure this out. We have the Indian Institute of Integrative Medicine in Jammu, but I'm afraid from whatever I've not been there, but what I hear of it is it's largely RCTs on specific Ayush drugs that are being tried and nothing beyond that. We have the community health officers now in the health and wellness centers, now called Arogya Mandirs, where they are either nurses or Ayush doctors who are being given a bridge course in modern medicine to be able to be community health officers. Now there needs to be much more than that. When their course was being created, the discussion was on geriatric care, and they were going to train the Ayush doctors in modern forms of geriatric care. So I was completely stunned, and I said, what are you doing? What, you are going to teach Ayurveda how to do old age care now? They said, yes, but that is what IGNOU's course is going to do. And that is what was designed. Okay, so I mean, there's this absolutely false kind of things happening in the name of integration and bridging. There was the clause in the NRHM, what is now called the Indian Public Health Standards, that in the sub-centers and PHC compound, we will grow the local medicinal herbs. It's part of what is supposed. No state has done it. No, but no state has done it. Kerala is doing it? Okay, great. When excellent. So if there would then be variations across the country, and there would be some, but most states don't even. In Pondicherry is very much part of that kind of structure. True. But most have not even bothered about. But can you again imagine that as just not just bridging, because you have the Ayush doctor sitting there. If you have the herbs being cultivated there and they are prescribed to the patients, the re-legitimization of that knowledge that will happen. Because it is your dominant system, the dominant institution of the government sitting there and saying, here are the herbs, use them for such and such. Completely reverse the delegitimization of knowledge process that has happened over these last 100 years. So it has a powerful possibility, but it doesn't work out. There is the Quality Council of India doing certification of folk healers, of local community healers. And a very interesting process, very rigorous process, and certainly something to be taken up. At the moment, 8 or 9 states are doing it. Others have not picked this up yet. There has been a suggestion for district health resource centers, creating those so that they can understand the local traditional knowledge, ensure that the plants that it requires are being cultivated there, interact with the Biodiversity Act and the Forest Department to ensure that that is made available to the local. And because our districts themselves are so large, they actually require block level and taluka level centers, but at least district level should be there to do this, but these are not yet taken up really. So basically, how do we do this kind of a dialogic process across these systems at the knowledge level and the textual knowledge level? Can we create something like, and this is again a proposal we had given which was shot down completely, a university of integrative medicine where you have each of the 8 systems having their own medical college which does research and teaching, and an integrative institute which helps to bring them together on particular sub-problems and figure out how would be best to do it. We did one very small exercise, and Dr. Mittal here was a part of that, dialogue on diabetes, where we took diabetes type 2 as our problem and had all 8 systems practitioners there as well as folk healers. And we all talked about how do you understand the disease and its pathology, its process of development, the symptoms, prevention and treatment. And it was interesting that the prevention that came out was similar for everybody. It was diet and it was exercise. So basically all systems had that understanding, and other things were different, of course, and so on. So that kind of a dialogic process, it was a very enriching experience. Unfortunately, we couldn't follow up on it, but it was an interesting exercise. We did that in JNU. The proposal for an integrated standard treatment guidelines. Each system has its own treatment guidelines. Can we create an integrated one so that when people also, now we are saying that they should, as Purnima ji was saying yesterday, try the dadi nani things at home, and at a certain point you have to then go to an expert. How do you know when to go to that expert? Should be part of the guidelines for people, that this is the kind of, when you reach such symptoms, then maybe this is the time to go.
Red flags. Red flags.
Red flag, exactly. But then also you can have different systems for which to go for what could be part of as a researched process, which is guidelines again. So those are some of the things which are already on the ground, and some which are at the level of ideas yet and as proposals and need to be taken up. But there are certainly possibilities today of moving forward on this agenda. So, but the problem is with the understanding of basic science, and it's making a big comeback. Let me also say that while there is sustainability science and all, which is doing more opening up and saying there are multiple ways of looking at it and etc., and psychosocial approaches and all, there is a comeback to say science as the classical science as we understood it, of the objective neutral kind which is value free and all that. So I think this is a politics of knowledge and a battle of knowledges that we need to be part of, and to see that we are able to be part of that which opens up to plural knowledges rather than go back to the singular knowledge.